the most key important thing is, does use reflect need? And how do those two relationships work? We see use, we see evidence of variation in use. We know that there's different elements of need. How do those two fit? And this is probably what we're really after. Probably in many countries, use probably doesn't reflect need. But it's how much it differs we want to know. Seeing this huge variation. And this is a GP in New South Wales, Julian Tudor Hart, in the 1970s, and he wrote this, which is really quite neat. In areas with the most sickness and death, general practitioners have more work, larger lists, less hospital support. They inherit more clinically ineffective traditions of consultations than the wealthiest areas. And hospital doctors shoulder heavier caseloads with less staff and equipment, more obsolete buildings, and suffer recurrent crises in availability of beds and replacement of staff. These trends can be summed up as an inverse care law, he quoted and said. And that the availability of good medical care tends to vary inversely with the need for population served. So, what he's saying here, and it's probably similar in your country and even today, we can see that the burden, the sick who need more care should have more care, but actually have the least. But the opposite is true. The wealthiest who need less care may have the best access and use and also the best care for them. How widespread is this, I wonder? Let's consider a couple of things. Birth, age. At birth, an elderly may have higher levels of need. And look at socioeconomic status, because we know poorer may have higher things. So these things we know. And let's have a look at the data. So this is a health expenditure for women in Netherlands, in Holland. And they followed up on women throughout. And they look at this, and then you look at this, and you go, oh, it looks about right. Age 0, you need healthcare, quite a little, because we know at birth, neonatal, intensive care, etc. You need some the first year of life. You may have childhood infections and you need care. And towards the latter, and this looks like it seems to reflect need. Then we have socioeconomic status from another study and the use of healthcare. Health visits to healthcare professional in the past 2 weeks by social status. So the top social class is 1 and 2, and then all the way to the most deprived, social class 5, we see that actually the most deprived have a higher visit and a higher visit to hospital and higher visit to health professionals. This also looks like direction seems to reflect need. Poorest, more hospitalization. This is GP referral rates per 1,000 people of a population. And let's look at this. The least deprived have less referrals, and most deprived have more referrals. This also shows us that actually use looks like it is reflecting need. Poorer, most deprived, have more referrals. But we must also want to ask ourselves, is this gradient steep enough? We know it's going in the right direction, but should it be even steeper? Should it be much lower for the least deprived and much higher for the most deprived? We don't know. Is it reflecting need well? To do that, we have to consider one more thing. The use-need ratio. It's necessary for us to consider the use to need to access to think about whether or not this higher utilization rates reflect a higher level sufficiently. Okay, so because it's difficult to know true need, we can use a surrogate and proxy measure of need. And then we want to compare that with different groups of using the same service. And then we also need to measure the demand side factors like morbidity and illness behavior. So this is use-need ratio. Now this is interesting, understanding a proxy measure of need. Because we don't know the true need for coronary vascularization and the true need of coronary heart disease, This is a study that's done for my school at LSHTM some time ago. They looked at different districts of UK referral for coronary heart, back then there's CABG, so coronary heart bypass surgery for people who have a cardiovascular disease. And we don't know necessarily the true need of cardiovascular disease in all the districts of England, but they have used the proxy measurement using the SMR, standardized mortality ratio. So on the bottom line, we've got standardized mortality ratio. And, we know that if it's above 100, the higher is worse, which suggests a higher level need from deaths. And we've got on the top here the rates of CABG, and we can see that actually there is an inverse care law here that in England, the districts with the lowest level of surgery have the highest SMR rates. Okay? So here, use is not reflecting need, okay? And where need is measured by proxy. And this is in England, which is very, it was surprising when this was founded. This is a system based on process equity. But we can see the inverse care law working here. Those who have the lowest level of surgery have the highest level of need. This is also interesting. This is from PROMS data. So in England, we do patient-reported outcomes for hip and knee, and they have found that those who are most deprived socioeconomically, in the 20% most deprived in the population, have more severe symptoms. The odds ratio, that's not odds. They have 3.6 points less on their score for severity. So they're more severe than those who are have a higher socioeconomic status. So they were in greater pain, had greater symptoms at the point when they had surgery. We don't know anything about those people who didn't access healthcare. This is just at the point when they had their hip replacement. And also those people who are more deprived have 11% more likely to have a longer history of symptoms than those who are less deprived. And these are statistically significant. Okay. This is also another showing measures of type 2 diabetes and different process by deprivation. And we can see that actually the trend is great. Okay, when we look at measuring demand side factors, this paper is very interesting as they've tried and attempted by Canadian researchers to look at not only morbidity but illness behavior, and this was the first. It's so hard to measure illness behavior. So they took two areas in Ontario, which is one of the provinces in Canada, and they measured low use and high use areas. They have looked at objective data as well, so they examined them, x-rayed them, and looked at the need in the population as best as they could. So they found that actually in the low use area, there was a population of 26,000 versus high use area. Then severity of arthritis does vary. So they did find that high use of hip and knee replacement areas have more severe arthritis than low use. So that trend works. But they also did the survey, which is the extra bit of trying to understand illness behavior, is asking them, do you want a hip and knee replacement surgery in their survey? And they also interestingly found that high use areas also want more surgery than low use areas. We thought we knew about variation in need, variation in disease prevalence, but what we didn't know before this study is, measuring illness behavior, is how the variation changes and how much people want surgery. And this is within one country, one province, and actually there's differences between how much people want surgery. Sometimes we might be criticizing for inequity. We're saying, oh, look, there's such a huge variation in use, such a huge variation. But actually what we don't know normally is how much there's a variation in illness behavior and demand for that. Sometimes there might be a good explanation for a difference. People just don't want surgery. You know, we are assuming that these people are given good informed decisions and making the right informed decisions for their treatment choice. There is differences. Okay, well, I went through all that, but hopefully that was giving you an overview. Thank you very much.